Hi friends, welcome back to Prosthesis. Myself Dr. Jolsna, and today we are going to discuss an important topic from the implantology section, that is the implant loading protocols. What do you mean by loading an implant? So it is the process of connecting a functional prosthesis to the implant fixture. So let us see the contents that you have to include in your implant loading protocol topic. The introduction first, then the important definitions, the various protocols of implant loading and detailing about the immediate as well as progressive loading, and then conclusion and finally references. So let us get into detail, and before that I request everyone to please do like and share my videos if you are finding them useful, and if you are new to this channel Prosthesis, please do subscribe and support me. If you have any queries, feedbacks, suggestions or any topic that needs to be discussed, please do comment below this video or you can mail me at this mail ID. So without any delay, let us start. Beginning with introduction. So the basic treatment goal of implant dentistry was the formation of a direct bone to implant interface without any fibrous encapsulation. So earlier dental implants were commonly loaded at placement because immediate bone stimulation was considered to avoid the crestal bone loss. And then Brennemark introduced the concept of osseointegration, where he showed that the direct bone to implant interface was possible and was long lasting when the implants were left to heal in a submerged way. So the classic protocols propose that implants should receive no loading during the osseointegration period. Since Brennemark introduced the osseointegration system, that is in 1977, various new protocols have been proposed regarding the prosthetic load timing, which we will be seeing in our coming slides. The definitions: osseointegration as per GPT-9, it is the apparent direct attachment or connection of osseous tissue to an inert alloplastic material without intervening fibrous connective tissue. So there is direct attachment or connection of the bone to the inert alloplastic material, that is the implant, without any fibrous connective tissue in between. So that is osseointegration. And what is occlusal loading? So here the implant prosthesis is restored to normal occlusal function and is in contact with the opposing dentition. So that is occlusal loading, and we know basically there are three types of loading. That is the immediate loading, where the implants are loaded 48 hours post surgery, and early loading, where provisional restorations were placed within 48 hours to 3 months of the implant placement, and then the conventional loading. So this is a two-stage protocol, where after placement of implants, an unloaded healing period of 3 to 6 months was followed up by loading. So these are the basic protocols, and let us see the various other protocols of implant loading. Here are the 8 different protocols of implant loading. That is a Brennemark's loading protocol, progressive loading, non-submerged single stage protocol, immediate functional as well as non-functional loading, early loading, delayed loading and anticipated loading. Let us see the features of these protocols. First one, Brennemark's loading protocol, where implant is placed in flush with the bone level and covered with gingiva, and the final prosthesis after 3 to 6 months of initial healing. So that is a two-stage protocol, and the patient is advised soft and later on hard diet. Then progressive loading, flush with bone level, covered with gingiva, but provisional prosthesis is brought progressively into occlusion depending upon the density of the bone. Again, soft or hard diet. Then the non-submerged single stage protocol, where the non-submerged implants are placed in flush within 1 to 2 mm of the gingival level. Patient is advised soft diet. And immediate functional loading, where temporary restoration is fitted on the same day as surgery, that is within 48 hours, and in occlusion, patient is advised soft diet. In immediate non-functional loading, the temporary restoration is fitted on the same day, that is within 48 hours, but not in occlusion. Again, patient is advised soft diet. And in early loading, the final crowns are within 3 weeks from surgery, and that is in occlusion. Patient is advised soft or hard diet. In delayed loading, the implants are subjected to loading after more than 6 weeks post surgery. And in anticipated loading, the provisional prosthesis is fitted after about 2 months post surgery. Again, patient is advised soft or hard diet. So So these are the various protocols, and let us see the Brennemark's protocol in detail. So the two-stage surgical protocol for implant placement and prosthodontic rehabilitation was established by Brennemark et al. In the year 1977 to accomplish osseointegration, that is direct bone apposition. And this direct bone apposition was possible at the implant surface and long-lasting at the condition that implants were left to heal in a submerged way. So this was the concept of Brennemark's two-stage surgical protocol. So here the implants were placed in flush with bone level and covered with gingiva, and final prosthesis only after 3 to 6 months of initial healing. So according to Brennemark, early loading was identified as a detrimental factor for osseointegration, and he supported the fact that osseointegration required a long healing period of at least 3 months in mandible and at least 5 to 6 months in the maxilla. Now let us see the prerequisites of Brennemark's two-stage protocol. So first one was countersinking of the implant below the crestal bone. So countersinking means it is the coronal flaring of the implant site. So countersinking of this implant below the crestal bone, obtaining and maintaining a soft tissue covering over the implant for 3 to 6 months. That is, implants are placed in a submerged way and there is a soft tissue covering over it, and maintaining a minimally loaded environment for 3 to 6 months. So one of the most emphasized requirement was a stress-free healing period of 3 to 6 months, and this made the implant treatment period also lengthier. Let us see the rationale for a delayed loading period. So if there is premature loading, it can lead to fibrous tissue encapsulation instead of direct bone apposition. Also, the necrotic bone that is present at the implant bed border, it is very weak and it's not capable of load bearing, and so this must be first replaced by new bone. So delayed loading period gives time for all these. And the rapid remodeling of the dead bone layer, it compromises the strength of the osseous tissue that is supporting the bone to implant interface. And finally, integrity of the periosteal margin may be threatened by the undermining remodeling of the adjacent bone, that is during the late healing period. So these are the reasons for a delayed loading period. So here we know that it is a submerged countersunk surgical approach. So this will minimize the risk of implant interface movement during bone remodeling, and thereby it prevents exposure during healing and it enhances emergence profile. So Brennemark and several other workers achieved predictable long-term clinical rigid fixation with the above protocol in both partially as well as completely edentulous patient. However, there were some drawbacks related to this type of classic loading protocol, and they were discomfort and inconvenience of the second stage surgery, and the treatment time was very extensive, so there was again patient discomfort, and the implant was mostly at risk of failure or crestal bone loss within the first year. So even if an indirect bone to implant interface was established and confirmed at post healing stage 2 surgery, even then failure resulted, that is because of excessive stress or poor bone strength at the interface during early implant loading. Challenging the very concept of Brennemark came two different protocols for loading of implant, that is the progressive loading, where the implant is restored in light contact initially and is gradually brought into full contact with the opposing dentition, and then the immediate implant loading, where the implants are loaded within 48 hours post surgery with an assumption that immediate bone stimulation was achieved when it's reduced the crestal bone loss. Let us see progressive implant loading in detail. So in the year 1980, Misch proposed the concept of progressive or gradual bone loading during prosthetic reconstruction in order to decrease the crestal bone loss and early implant failure in endosteal implants. So his concept was that when there is tension during prosthetic phase that increase gradually without overloading the implant, bone can react by increasing its formation, growing denser and improving its quality. That means bone can mature when there is tension during the prosthetic phase that increase gradually without overloading the implant. So this protocol uses transitional prosthesis that is made up of acrylic resin that minimally disturb the integration of the implant bone interface during the healing phase. And the progressive bone loading protocol is more critical for lesser bone densities because they are several times weaker than those with significant cortical bone. So the ultimate aim of progressive bone loading was to increase the density of the bone, decrease the risk of implant bone interface failure, and also to decrease the crestal bone loss. Let us see some of the factors and concepts that is related to progressive loading. So first one is bone density. So according to Wolff's law, every change in the form or function of bones or of their function alone is followed by certain definite changes in their internal architecture and equally definite alterations in the external conformation in accordance with mathematical laws. So Wolff's law states that if there is a change in the form or function of the bone, or if only there is a change in the function, there is definite change in the internal architecture as well as external conformation of the bone, that is in accordance with mathematical laws. So this phenomenon occurs throughout the skeletal system, and so studies prove that if the bone is immobilized for a period of 3 months, there was a 15% decrease in the cortical plate and extensive trabecular bone loss, whereas when there was a bone disuse, cortical bone decrease was around 40% and trabecular bone decrease of around 12%. So in case of tooth loss also, generalized loss of bone volume and density is seen, and that is because of a decrease in micro strain to the bone. So this density decrease can be related to several factors like the period of edentullousness or the original density of the bone, muscle attachment, bone flexure or torsion, parafunction before and after tooth loss, hormonal influences, systemic conditions, etc. So according to Wolff's law, bone responds and remodels in relationship to the forces upon it, and this is directly related to the amount of microstrain. That is, bone remodeling replaces the existing bone with the new bone, which is controlled primarily by the amount of microstrain within the bone. So in progressive loading also, we introduce gradual loading, that is, the bone is able to respond to the increased stress which is within the physiologic limits, and that is by increase in density. And the load is distributed or introduced to the surrounding bone in a scientific and mathematically perfect fashion, and this will produce the most favorable bone and clinical situation for long-term implant success. Next, coming to Harold Frost's Mechanostat Theory, where he demonstrated the bone response to strain, that's the bone adaptation to loading. So Frost showed that increase in bone mass is related to the strain that is applied to the bone. So he developed a mechanical adaptation chart relating different types of loading to the ranges of strain that is applied to the bone. So there are 4 microstrain zones, that is the disuse atrophy, the steady state, physiologic overload and pathologic overload zones. So whenever there is a strain that is perceived by bone tissue, it initiates a chain of reaction of events that results in bulgic response, and it is usually the bone cells along with the extracellular matrix that comprises the strain sensitive population. So there are 4 types of zones, and among these, the disuse atrophy zone and the pathologic overload zone, they result in a decrease in the bone volume, whereas in steady state zone, that is a formation of organized, highly mineralized lamellar bone, that's a favorable bone, and the physiologic overload that covers a range between 2000 to 4000 microstrain result in an increase in bone mass, where the bone formed is woven bone, that is an immature bone that is less mineralized, less organized and consequently weaker than the lamellar bone. So you can see here, in the disuse atrophy, the bone mass is less, and then in steady state it's a remodeling happening, and as we go on, when there is a pathological overload, it results in fracture of the bone. So this is the bone response to strain described by Harold Frost. Again, Frost has reported 4 distinct microstrain patterns within the bone. So the first one is the acute disuse window, which results in atrophy. The second one is the adapted window, where physiologic response of organized bone happens. So at this level of strain, the bone remodels and remain as an organized mineralized lamellar bone. So this is called as the ideal load bearing zone for implant interface. So that is the adapted window. Then comes the mild overload window that corresponds to fatigue fracture, and here woven bone formation happens. So this is an intermediate level of microstrain between ideal load bearing and pathological overload. The next one is pathological overload that causes bone resorption, and the bone fractures at around 10,000 to 20,000 microstrain units. So these are the 4 distinct microstrain patterns described by Frost. Many studies shows that cyclic or dynamic loading is necessary for bone remodeling. So the effect of applied strains on the bone depends upon the rate of change of applied load, the magnitude of the load as well as the duration of the load. So greater the rate of change of applied strain in the bone, the more is the bone formation, and lower magnitude for many cycles can produce the same anabolic effect than that of the greater magnitude force that is applied for shorter duration. That means low magnitude for many cycle, the effect is same as that of greater magnitude of force for shorter duration. So this shows that a cyclic or dynamic loading is necessary for bone remodeling. To the relationship between bone density and strength. So several studies shows that bone strength is directly related to density. So we know the Misch classification of bone based on their densities, that is D1, which is the most dense bone, that is dense cortical, D2 porous cortical and coarse trabecular, D3 porous cortical and fine trabecular, D4 that is fine trabecular, which is the weakest bone. So Q et al. In his study showed that D1 bone is 10 times stronger than D4 bone to stresses that cause microfracture. Therefore, increasing the bone density around an implant increases the strength of the bone, and thereby it can help avoid the crestal bone loss and also the implant failure. So Bides et al. In his finite element analysis showed that progressive loading can also help to increase the strength of the bone. So if we increase the strength, thereby increasing the bone density, and that will decrease the implant failure. Now let us see the bone implant interface. So functional loading of implants brings about biomechanical influences, and that greatly affects the bone maturation. So studies shows that an increase happens in the density of the peri-implant bone structure over a 6-month to a 4-year period after the implant was placed. So when there is a rigidly fixed implant, the greatest stress happens at the region of the crest, okay, and there the premature or excessive functional load can overstress the system and cause bone resorption. So when there is a stress that is applied to an implant that exceeds the physiologic limit of the bone density present around the implant, that leads to implant failure. Whereas when the bone responds to physiologic force, there is a gradual increase in the load during the prosthetic fabrication, and that stimulates an increase in density. So when there is progressive bone loading, it can stimulate increase in bone density. So all this shows that progressive bone loading aims at increasing the density of the bone, decreasing the risk of implant bone failure, and decreasing the crestal bone loss. So the progressive loading protocol is more critical in case when there is fewer number of implants, soft bone type, and higher risk factors, that is presence of cantilevers or excessive patient force or implant position, etc. And when there is full arch prosthesis with little or no cantilever, or when there is adequate implant number and positions are favorable, they rarely require progressive implant loading. So when there is favorable biomechanics of an arch, immediate loading protocol is the suitable one. And we have already said that progressive loading is more critical for lesser bone densities because they are several times weaker than those with significant cortical bone. So when there are other factors like parafunction, cantilevers, or other stress magnifiers, all these cases progressive loading will be a better option. Now, the principles of progressive loading are best demonstrated in cement retained prosthesis and are least applicable for screw retained bar of a mandibular removable prosthesis like RP5. So, what are the reasons for this? One is that the transitional prostheses are movable during the fabrication phase, and the torque force applied to a screw is greater than that of the bite force. So, when such high force are there, the long healing time are suggested, and so this screw retained prostheses are difficult to load progressively. Next is the elements of progressive loading. So, according to Mish, 5 elements are there. First is the time interval, then the diet, occlusal material, occlusal contacts, and prosthesis design. So, let us see one by one in detail. The first element is time interval. So, Brennemark's two-stage protocol separates initial implant placement and the stage 2 uncovering by around 3 to 8 months. Whereas in progressive loading protocol, usually the 5 major prosthodontic appointments are made and are separated by some specific time interval, and that is depending upon the bone density observed at the initial surgery. So, we know that the Mish classification of bone based on density, that is D1, D2, D3 and D4. So, depending upon the density that is present at the initial surgery, we have to separate the treatment appointments by specific time interval. And along with this, the dentist attempts to gradually increase the loading to the implants at each prosthetic step. So, here you can see the chart of the bone densities and the treatment times given. So, here the macroscopic coast-trabecular bone, that is a D2, heals about 50% faster than the D1 bone. But although it heals slowly, the D1 bone has got the greatest strength and the greatest lamellar bone contact. So, D1 has got greatest strength and great lamellar bone contact, even though it heals slowly than D2. So, the healing time between the initial and second stage surgeries is almost kept similar for D1 and D2, that is around 3 to 4 months. Whereas you can see in D3 and D4, the initial healing time is 5 and 6 months. That is much more time we have to provide for D3 as well as D4. This is because they have got lesser bone contact and also decreased amount of cortical bone. So, we have to give time to allow for the maturation of the bone implant interface and also for the development of lamellar bone, which is the ideal bone. So, D3 and D4 has to give more time, whereas D1 and D2 you can give similar time, that is around 3 to 4 months. Now, let us see the 5 major prosthodontic appointments in progressive bone loading protocol, which are separated by specific time interval depending upon the density of the bone that is present at the time of surgery. So, the first step is initial abutment selection and preliminary impression. So, this appointment may occur during the suture removal appointment after stage 2 surgery or during the uncovery procedure. The next step is final impression and transitional prosthesis, where the appropriate abutment is selected and the dentist threads the abutment for cement retention into position. And then the final impression is taken along with centric occlusal registration or face bow record along with the protrusive and check bites. And then the third step is metal superstructure try-in and transitional prosthesis 2. The fourth step is initial insertion of the final prosthesis, and finally the final delivery and evaluation. So, I am not detailing these steps. If you want to know in detail about the progressive bone loading appointment sequences for partially edentulous and completely edentulous, do let me know by commenting below this video. Next element is diet. So, the dentist controls the diet of the patient in order to prevent overloading during the early phases of the restorative process. So, soft diet is advised that is required where the masticatory force limit is 10 pounds per inch square, and this is during the transitional prosthesis delivery. And a medium diet, that is where the masticatory load limit is 21 pounds, and that is during initial delivery of the final prosthesis. And a hard diet is advised when the masticatory force limit is 27 pounds, and that is during the final evaluation of the final prosthesis. During the initial healing phase, the dentist instructs the patient to avoid chewing in the area of the implant placement, and once uncovered, the implant is connected to a abutment, and that is at greater risk of loading during mastication. So, from the initial transitional prosthesis delivery until the initial delivery of the final prosthesis, The patient is limited to a soft diet and masticatory force limit here is 10 psi. So the soft diet not only minimizes the masticatory force on the implants and also overloading of implants, but also decreases the risk of temporary restoration fracture. After the initial delivery of the final prosthesis, patient may include slightly tougher diet and the masticatory force limit is 21 psi, and after final evaluation appointment the patient may include raw vegetables, that is a hard diet that requires a masticatory force of 27 psi. So a normal diet is permitted only after evaluation of the final prosthesis function, occlusion and proper cementation. So this is about the element diet. Next element is occlusal material. So the occlusal material may be varied in order to load the bone to implant interface gradually. So during the initial stages, the implant has no occlusal material over it, and at subsequent appointments, the acrylic can be used as an occlusal material which has got the benefit of lower impact force than metal or porcelain. And if there is any parafunction or cantilever length which cause concern related to the amount of force on the early implant bone interface, the dentist can extend the softer diet and also the acrylic restoration phase several months. So in this way, the bone gets a longer time to mineralize as well as to organize in order to accommodate the higher forces. And in final restoration, either metal or porcelain can be used. The next element is occlusion. So the dentist gradually intensifies the occlusal contacts during prosthesis fabrication. No occlusal contacts are permitted in initial healing time, and the first transitional prosthesis is left out of occlusion, and there should be no cantilever made in the transitional prosthesis of edentulous patients. And at transitional prosthesis stage 2 appointment, occlusal contacts similar to those of final restoration for areas supported by implants. However, occlusal contacts are avoided on cantilever. And finally, the occlusal contacts on the final restoration follows the implant protective occlusion guidelines, and the occlusal table is also kept narrow. Final element, that is the prosthesis design. So during the surgical stage 2 uncovery procedure, the surgeon evaluates the clinical mobility, bone loss both horizontal and vertical, and proper placement and angulation to the load, and zones of attached gingiva, gingival thickness, etc. And in the initial healing phase, dentist instructs to avoid any load on the implants, including soft loads. And the first transitional acrylic restoration in partially edentulous patient has no occlusal contacts and no cantilever. And the main purpose of this is to splint the implants together to reduce the stress and to have implants sustain the masticatory forces solely from chewing. And in second acrylic transitional restoration, occlusal contacts are placed on the implants with occlusal table similar to that of the final restoration, but no cantilevers in the non-aesthetic regions. And finally, the final restoration has final occlusal table and cantilevers and has the occlusal contacts following the IPO guidelines. Next section we are going to discuss is immediate implant loading, which will be continuing in our next session. So thank you all for watching my video. Please do like and share my videos if you are finding them useful. And if you are new to this channel ProstheHub, please do subscribe and support me. If you have any queries, any suggestions, feedbacks or any topics that need to be discussed, do comment below this video or you can mail me at this mail ID. So bye from ProstheHub until our next session.